We're now going to move into a discussion that brings the topic of cancer more to the site of care. We've heard a lot about where the leading technology and thinking is going. But in our next segment, we'll hear from Dr. Rakesh Suri, the Chief Executive Officer and Chief of Thoracic and Cardiovascular Surgery here at the Cleveland Clinic in Abu Dhabi. He oversees the hospital's overall strategy and operation as the first ever U.S. multispecialty hospital replicated outside of North America. Previously, he was Chief of Staff at the hospital, where he led the recruitment of more than 400 physicians and managed the medical staff to deliver complex and innovative services, and we'll hear about those in a moment. We'll also hear from Dr. Dale Shepard, who's the director of the Taussig Phase 1 and sarcoma programs at the Cleveland Clinic in Ohio. There, he oversees the early development of new cancer therapies, including genomic-based treatments and immunotherapies that are revolutionizing the care of patients with cancer. He's been the principal investigator for dozens of clinical trials and recently received a National Cancer Institute award. So please, Dr. Suri and Shepard, join me on the stage. Thank you. Terrific. Dr. Suri, we'll start with you. I'm a visitor to your home here, and as I say, we've heard a lot about sort of the theoretical advances, but talk to us about the practical realities of delivering cancer care here in Abu Dhabi.
Thank you so much. It's really a pleasure to be here today. There's so much going on globally in healthcare, not only in oncology, but truly global academic medicine. And I think it's probably a good place to start our discussion today as we think about cancer moonshots. You know, there's three things about global academic medicine I'd like you to think about. The first is that it's a great business model. You think about what truly people need, and it doesn't depend on the price of oil or how hard the wind is blowing. And you look left in your seat, look to your neighbor to the left, and look to the neighbor to your right, and literally everybody in the room requires medical services. And what's important is that people often felt in the past that the hospital and the clinic was a place to be avoided. And that paradigm is changing. We know that the earlier we see patients in health, the more likely we are to be able to keep them healthy for years to come. So that's the first thing. It's an enduring business model that'll always be there. The second is that truly great global healthcare is very rare. It's very uncommon. So to actually find a great doctor and, importantly, a great team is very difficult in many, many parts of the world, including the US, I might add. And the third is that a robust, fully integrated healthcare system, we know, is a predicate for societies to thrive. Moreover, it speaks to the visionary capability and the effectiveness of leadership. So those are three things that I want you to think about as we begin our discussion on the cancer moonshot. Now, let's talk about Cleveland Clinic Foundation for a second. Many of you might take this for granted, but we are the first truly global healthcare brand in existence. The first truly globally integrated multi-specialty practice in existence. That then means that for the first time in history, a patient can walk into the doors in Abu Dhabi or now Al Ain and have access to the same people, processes, equipment, and infrastructure as they would have in Cleveland, Ohio. Moreover, those doors of entry include Florida, Toronto, Abu Dhabi, and now London. That's truly remarkable if you think about it. There's 57,000 minds working together as a team of teams to deliver cutting-edge care, and the cancer moonshot will be intimately predicated on the ability to replicate that model globally. Now, people often ask me as they come to see our beautiful building, Cleveland Clinic Abu Dhabi, I mean, the rulers of this nation have allowed us to construct a truly remarkable campus. I'm humbled to say there's no more beautiful, more sophisticated chassis on the planet in healthcare. But beyond that, people ask me, what are the factors that led to Cleveland Clinic Abu Dhabi being so successful so early out of the blocks? Just merely less than 3 years of having been open. And the first is there was a recognition of a dire need of the population. Just 3 years ago, a patient with a diagnosis of heart disease, brain disease, respiratory critical care disease, or digestive disease, the first call they would make is not to the doctor, but to the airline. And I'm proud to say that we've now changed that, stopping patients from having to leave their homes for the treatment of these conditions. So the first was the dire need of the people. The second was the truly inspired vision of the rulers and the leadership and the regulators of this great nation. We have never before in the history of medicine seen such a coalescence of the need of the people and the visionary, inspired leadership that it took to make this happen. But importantly, people often forget the third thing. It takes great, inspired, committed stakeholders to make these things happen. It's a day-by-day journey that's spanned over a decade. And those two stakeholders are Mubadala and Cleveland Clinic Foundation. And they took a risk on each other. A risk on each other that they felt that we could uplift and enhance the health of this nation and this region and become a global hub for healthcare. And that's truly what has rapidly emerged. What do we offer at Cleveland Clinic Abu Dhabi, just for the sake of completeness? Many people are surprised to learn that we offer the same type of brain and neurologic care, eye care, heart and lung care, and digestive disease care as we do throughout our global branches. And this is now expanded into transplantation and genomics. Proud to report that we have just completed the 4th solid organ transplant system merely 3 years from having opened. Never before in the history of medicine has heart, lung, liver, and kidney transplants been performed in such a nascent healthcare system. And this is, again, truly speaks to the support from the leaders and the investment of the stakeholders. So what's my job as a CEO? My job as a CEO, along with my leadership team, is to bring 100 years of clinical excellence of the Cleveland Clinic Foundation right here to Abu Dhabi to create a local and regional and global hub for the highest complexity and coordination of care. And I do this, and we do this by focusing on 3 things, and I want you to remember this because this is a hallmark of the care we deliver. The first is we are a patients-first organization. We are here because of our patients and not them because of us. The second is that although we invest in technologies and buildings and all the wonderful things that we can speak about that are very exciting to highlight, our most important investment is in our people. And we believe that by bringing people and developing them and developing their careers, that they will meet and exceed the expectations of our patients. And the third is that we need to now sustain what we've begun here. And that includes a rational discussion on expanding into cancer, which we now perform surgery and chemotherapeutic and some genomic treatments for. And Dr. Shepard will be speaking about how we'll proceed in this regard towards the so-called moonshot. But also sustaining the caregivers that we've brought, them and their families and their careers in a financially sustainable manner for decades to come. So with that, I'd like to introduce Dr. Dale Shepard, who's a leader, not only globally, but at our Taussig Cancer Institute in Cleveland, Ohio, who will be speaking about how we intend to march our way towards these moonshots, one cancer diagnosis at a time.
Terrific.
There you go.
So we've heard a lot about the leading edge of technology, or at least discovery. Give us the practical sense from exactly as Dr. Suri said, your experience.
Yeah, I mean, when you look at our ability to treat cancer, it is truly a revolutionary time. We have seen progress in the last few years, last 3 or 4 years, that is unrivaled. We have a lot of immunotherapies that are now available. There's a whole range of new therapies with genomic therapies. They present challenges, right? So there's great opportunity. Within immunotherapies, there's a category called checkpoint inhibitors, which are now approved in 9 different cancers, and they make a dramatic difference. I've had a patient with a bladder cancer that has had 3 lines of therapy, metastatic disease. There is nothing that would be known to work. He received one of these checkpoint inhibitors, and literally his tumor melted away. And 3 years later, he still doesn't have evidence of cancer. So these can be absolutely revolutionary in terms of their ability to treat cancers. But they also provide a lot of opportunities, because just like a lot of our chemotherapies, they really are only effective in a minority of our patients. So if you look at the ability of us to predict who's going to respond, we just can't at this point. We have tremendous opportunity. These exceptional responders, the National Cancer Institute is looking into, can we identify what is it about these patients that lead them to have a dramatic response? Can we figure out who's going to quickly fail them? These are very expensive therapies. They set up very high patient expectations. Can we predict which patients are going to respond? Similarly with genomics, there's a lot of excitement around genomic-based therapy. So traditionally when we treat solid tumors, we treat by geography. We treat a colon cancer like a colon cancer, a lung like a lung, a breast like a breast. And across the board, the response rates are relatively low. I manage expectations as much as anything. When I see a patient, when they get their first scan, the likelihood that they have significant shrinkage of tumor is probably about 20 to 30%. We can't predict who those patients are going to be. So we sometimes go to genomics. So much like we heard earlier about genes and sequencing and things, can we sequence the tumor? Can we figure out where there's an abnormality that might be driving that to be a cancer? And then can we use that genomic abnormality to then choose a therapy? So maybe we're going to treat a colon and a lung and a breast cancer exactly the same because we're treating the genomic cause. The problem is that there's a lot of excitement about this area. We have therapies that are very effective. They can give 80 to 90% response rates, but only 1% of patients have a tumor with that abnormality. So it's tremendous excitement, but tempered excitement.
So we have a growing armamentarium of responses, of treatments. When we think about the investment and the learning that you're very much a leader in, how much is going on the development of new treatments and how much is on the predictive side, which will help make sure that the right people are getting the treatments?
Yeah, so there's less on the predictive side at this point. Certainly we are looking to see if we can find some way to separate patients into responders and non-responders. Within drug development, I hope that we're on the right track, but there's reason to be optimistic. There's reason to be somewhat concerned. There's certainly a lot of the genomic sort of trials that I mentioned in the past, and part of this whole notion of getting cancer care in place very much involves getting clinical trials, providing patients with leading-edge technologies and getting clinical trials as a potential. But our ability to measure genomic changes far exceeds our ability to do anything about it. So if I send off a genomic panel, I can see any of 300 different abnormalities. I might have 20 of those that I have a drug that I can utilize. And so we very much need more druggable targets. Can we find something to treat them? All right. So that's one aspect. We're doing a lot of immunotherapy trials. Unfortunately, a lot of the immunotherapy trials are looking to improve responses in situations where we already know they work. And so if you look actually worldwide at the availability of trials for very common cancers, they're lacking. And so at this point, things like prostate cancer, things like pancreatic cancer, and things like colon cancer, which are very common, have not historically responded to these checkpoint inhibitors. And there's actually a significant shortage of trials. So people with those three diagnoses have a significant lack of treatment choices.
Dr. Suri, you said great care is rare, and probably many people don't know that, but it certainly is true. And you also described an integrated model, maybe a term or a concept that has an intuitive sense, but I think it would be helpful to Tell us a little more about what that means to the patient.
Thank you. That's a really good question. So I was at Harvard Business School last year working with two luminaries in I would say business and medicine, Michael Porter and Robert Kaplan. They defined a concept known as the integrated practice unit, upon which was founded the concept of institutes at the Cleveland Clinic. What does that mean? Institutes means caring for the patient, as the disease, and not as a department of medicine or department of surgery or department of oncology. So what was interesting is when we were discussing with Kaplan and Porter how we can create the healthcare system of the future right here in Abu Dhabi, he turned to me at one point and he said, I can't even get this in Boston, Massachusetts. So this highlights how rare it is to truly receive integrated care. And if you want to stand back and have a look at what that means for a second, walk with me through this journey. So put your hand up in the room if you've ever been told you have or may have a heart murmur. Yeah. So either someone's embarrassed or they don't know, because roughly 5% to 6%, depending on the population of people, have a heart murmur. And then oftentimes when a parent is asked when a child has a heart murmur, what's to be done, they say, it's innocuous, it'll be fine. Well, that's just simply not true. What has to happen for heart murmurs, and sorry, Rima, will tell you what we have to do with you, is to get an echocardiogram before people are sick, before people feel the scourges of disease. It's extremely important. Be seen by a cardiologist and be seen by a heart surgeon long before they may require surgery or an intervention, or perhaps they would never need it. But the point is to be followed, to forego the need for therapy as long as possible, and then when therapy is delivered, to actually follow how people do thereafter. So if you think about that, that's an end-to-end healthcare system that is not transactional, that's not counting or driving revenue on a per encounter basis, but actually looks at the disease course through the patient's life cycle. So that's what I mean about integrated care, and that is strikingly rare. If you think about the fact it doesn't exist in Boston, Massachusetts, it doesn't exist in London, England, it didn't exist in Abu Dhabi, that's the kind of model that we've brought here to the region that we hope to be a beacon for the world.
So since Tal introduced us to the linkage between medicine and art, I have to say, as I was listening to you, when we got the tour of the Louvre Abu Dhabi, the first thing that was explained to us was that each of the chapters is integrative. It's not department by department of art in the traditional sense. So it seems to be a theme here, not just at the Cleveland Clinic. And so. Just a thought.
Actually, I'll just speak to that for just a quick second. That is not a trivial matter. Many healthcare systems around the world incentivize physicians and caregivers of one sort or another for seeing a patient or doing a surgery or delivering a drug. That's not how we work. We work in a following matter, regardless of where a patient enters the system, we get the patient to the right person, right place, right time for the right therapy in a non-incentivized fashion. None of our caregivers, none of our physicians are financially incentivized by the number of patients that they see. And that speaks to exactly what you said. The patient is at the center of every discussion, which is extraordinarily important in cancer care. It may be that the patient requires psychotherapy, or maybe requires meditation, or yoga, or genomic analysis. And it's important that the future of healthcare, future of oncology care, cancer care, be seen in this multidisciplinary fashion.
Dr. Shepard, as you were talking about the limited number of trials, I was struck again by our two presentations earlier in the afternoon. We're not coming out of traditional clinical medical settings. I didn't hear NIH referred to once. I heard Google and things like that. So can you talk to us about sort of, again, the permeability between the traditional academic medical center and the research enterprise there with these new ideas that come from other places?
Yeah, I mean, I think that's one thing that's been dramatically different here within the last few years is that there used to be a lot of siloed sort of development, pharma development, NCI-based development. In recent years, within the last 2 or 3 years, there's been a dramatic improvement in collaboration. And so NCI is working much more closely with pharma to get drugs into sort of investigator-initiated trials. Foundations are becoming more involved. We're working more with non-traditional sort of companies, things like Google. We are working with IBM and Watson and trying to utilize big data. So when we think about the genomics data, for instance, it's, traditional drug development is you take 800 patients and you give them one therapy, a standard therapy, and you take 800 patients and you give them your therapy you think is going to work better, and you see which one wins. But in this modern genomics era, you find a genomic abnormality, you give a drug, and you're hoping it works. And so we're trying to use those sort of one-off experiences, collect the data, use big data to see if we're actually impacting care, because you can't do those in a generalized way. And so there's a lot more collaboration, so infinitely better. Just to sort of, about the sort of care models, cancer is absolutely a team sport. You have to have surgery, you have to have radiation, you have to have medical oncology. You have to have people working seamlessly, and that's one of the great opportunities I have is that we have tumor boards that everybody, all the cases are presented, very standardized cares. We have care paths, so if someone comes in with a diagnosis, we suspect a particular kind of cancer, we have a sort of a blueprint, if you will. These are the sorts of tests that need to be done, very standardized. We have a very standardized way that this is what the patient's going to need in terms of surgery versus chemo versus radiation, and what order. We have very standardized follow-up in terms of surveillance. And so we've actually opened a new building about a year ago, and it's very patient-centered. It's again, treating cancer based on a very patient-centered philosophy. You walk into our building and you're met with patient education center. There's art therapy, there's yoga, there's a place where people can get wigs or hats. When you go to our treatment areas, it's very integrated so that patients are always seen in the same area of rooms. There's a small pod of rooms. If they need to see a surgeon, a medical oncologist, or a radiation oncologist, we come to them. And so the patient sits in one room, we come to them. If they need chemotherapy, they go to the other end of the building, and they're always seeing the same nurses in the same area. So very patient-centered. It's very, we think it provides much better quality care.
So last question from me before we turn to the audience. Can't talk about cancer without talking about the price of the drugs that are used to treat. And I mentioned in the opening the CAR T, but even standard chemotherapeutics are very expensive. How do you handle that in a patient-centered world?
Well, I think there's a couple of factors. I think, we have to make responsible decisions in terms of what we're treating with. Again, following care paths and sort of following along standard ways to treat improves quality and decreases cost, because you don't have people sort of doing these sort of rogue things to treat. In the United States, we have commercials on television for these checkpoint inhibitors. Everyone seemingly thinks they need one. It doesn't matter if it's approved for their cancer or not. They saw it on television, it must be great, I want it, right? And so by using care paths, we can avoid that sort of thing. You mentioned before about not being incentivized. I have absolutely no idea what kind of insurance people have. I have to be fiscally responsible, but I don't make any decisions based on cost. I do it because it's the right things, right? And so that's very much how we operate. But I think the key is going to be these things like selection of patients. Before I launch into giving a checkpoint inhibitor that's $90,000, do I have a good sense of whether that's the right therapy for that patient? And that's where we need to get to for lowering costs.
So as the guy who has to pay the bill, I have a few more comments.
A different perspective.
So by the way, this is a ubiquitous worldwide problem. undoubtedly, the years of research dollars that are necessary for such a drug to emerge are not insignificant. There's no question. But here's the thing. Driving up the costs of supplies, implants, and pharmaceuticals unilaterally without some system-wide justification or responsibility is not the right thing. It's not the right thing for people. It's not the right thing for healthcare systems. It's not the right thing for governments. We need to advance this discussion more rapidly, whether it's in the US, whether it's in Europe, or whether it's here in Abu Dhabi. And I'm proud to report that we're working very avidly on this front with the Department of Health, with the Ministry of Health, with other stakeholders, and with the drug and device companies themselves. So I'm very enthusiastic that we will have a much more responsible means of reimbursing the drug and implant companies in the future.